Good evening, everybody. As introduced, my name is Rick Haas. I'm a radiation oncologist in Amsterdam and very recently also in Leiden. So I'm working in two universities offering my services to sarcoma research, and I'm very pleased with the very kind introduction. Good evening, everybody. As introduced, my name is Rick Haas. I'm a radiation oncologist in Amsterdam and very recently also in Leiden. So I'm working in two universities offering my services to sarcoma research, and I'm very pleased with the very kind introduction. I am told that I am going to have my presentation, and I have to tell you when to advance the slides because I wasn't able to download the software. I wasn't allowed by my administrator. So every now and then during my presentation, I will say next slide. Or slide number 2. I will say next slide, or slide number 2, and then we'll proceed during and in the course of my presentation. What I would like to discuss with you this evening is that there are things in the management of extremity soft tissue sarcomas that we know, but there are many things we need to be addressed in future research. In the next slide, I disclose my relationships to pharma. And in slide number 3, I will highlight some, just to name a few of these unanswered questions. The first question would be nowadays. The second question is, what happens if you refrain from radiotherapy? What total dose should we prescribe for patients? And in what fraction size or what daily dose are we going to administer the total dose with? In slide number 4, I show you that our basis for the knowledge right now is coming from a large Canadian study randomizing postoperative radiotherapy to preoperative radiotherapy. It was published in 2002 by the group of Brian of Princess Margaret Hospital in Toronto, a very large and one of the largest sarcoma centers worldwide. And till that time, till day of publication in 2002, postoperative radiotherapy was the standard. For many centers worldwide, it is still the standard. But this trial, for the first in time, was an equal local control probability, an equal chance of curing an arm of a leg of a sarcoma if you either perform surgery first and then postoperative radiotherapy, or do preoperative radiotherapy first and then perform surgery. The study had as a study arm comparing 66 gray, that's 33 fractions in 6.5 weeks, to 50 gray, which is 25 fractions in. We now know from coming from this study, showing in slide number 5, is obviously the first question: does everybody need radiotherapy? So what happens if you do not irradiate? The question in slide number 6 is the alternatives we can, the fraction size per patient, and what is the total dose per patient we need to go to, and how long time does that take to deliver that radiation regimen. In slide number 7, I highlight the question that perhaps, as in many cancers till today, we combine radiotherapy with systemic compounds. We combine radiotherapy with chemotherapy, either by intravenous administration or sometimes oral drugs. Why not investigate in the setting of sarcomas a combination of radiotherapy with conventional chemotherapy, or the modern drugs like targeted agents? In slide number 8, I highlight what the Canadian trial has delivered us in the very important Lancet paper in 2002. Looking at several years follow-up until 3 years, you will see of preoperative radiotherapy and postoperative radiotherapy, they overlap, with a local control of 92 and 93% at 5 years for both regimens. In slide number 9, I show you that if you decide, for whatever reason, you are going to irradiate your patient preoperatively, then going to irradiate your patient preoperatively. Then, based on that Canadian study, the preoperative standard should be a 1.8 to 2 gray fraction. The Americans are more fond of 1.8 gray fractions. Here on this side of the Atlantic, so in Europe, we are more adept to 2 gray per fraction, and this has more to do with habit. So that's a choice between regimens you have. These fraction sizes, whether it's 1.8 or 2 gray, are delivered once daily, and so you attain a total dose of 50 to 50 modulated radiotherapy. That is a highly sophisticated technique focusing the radiation to the sarcoma and delivering the lowest dose to normal muscles around and normal bones. That is preferred for practically most, if not all, patients. That regimen will take 5 to 6 weeks. Several weeks, and several is a broad advice. It could be classically it's about 6 weeks, but there's no harm if you wait 4 weeks. It's not bad to wait 8 weeks. So that is how logistics can work. And after this delay, in which the normal tissues, especially the skin, can recuperate from the preoperative radiotherapy, then you perform your surgery. And if you decide on this regimen, you do so obviously and always in a multidisciplinary team. You don't decide it upon yourself. Each other that if you're going to perform preoperative radiotherapy, you must acknowledge and you must know that the chance of a wound complication by the surgery after preoperative radiotherapy, that chance will go up. If you decide to do surgery first and then do the standard 6.5 weeks postoperative radiotherapy, you will know that your late complications will go up. If you decide in your multidisciplinary team to not irradiate at all, you balance the complications of your treatment to the chance of a local recurrence. And all these considerations are valid and adapted to an individual patient. So let's first have a look at what happens if you do not irradiate at all. So the question is, does every extremity soft tissue sarcoma patient actually need radiotherapy? Now, first of all, I have to acknowledge that in this talk, when I'm talking about sarcomas and the addition of surgery and radiotherapy, obviously I mean the tumor types that are of immediate and high-grade histology, so the more aggressive tumors, the ones that are 5 centimeter or larger, and the ones that are deep-seated, so deep into the muscles of an arm or a leg. Seated, so deep into the muscles of an arm or a leg. There are, and that's the minority, there are low-grade sarcomas, like low-grade liposarcomas, which is a typical example of that group, that can be relatively small, that can be relatively superficial, and for those diseases with a very low chance of metastasizing, you can decide, I do, for the first time a patient needs treatment, I do surgery alone. And then I see and I watch the patient if anything is going. So I'm not talking specifically about these low-grade tumors. I'm talking about the aggressive. The question is valid. Does every extremity sarcoma patient actually need radiotherapy? On slide number 14, I turn the question around. So in need of radiotherapy would also mean actually that if you refrain from radiotherapy, how much more local recurrences are you going to see when refraining from radiotherapy? On slide number 15, I show that if you want to have an answer to that question, you will have to go into the literature and look at randomized trials, trials where patients were randomized to treatments, and looking at the arms and the groups of patients that did not get radiotherapy. And there is from the Memorial Sloan Kettering Cancer Center, that's a very large oncology center in New York. Slide number 16, I summarize 2 main studies published in 1996 and 1998, looking at surgery alone. And let's look at the top panel first, the study by Pisters in 1996. That was a study randomizing surgery alone and half of the patients, 80 patients, got surgery plus brachytherapy. Brachytherapy is delivering radiotherapy during a surgery by inserting catheters and putting the radiation in there. Now, what PISTA showed is that by surgery alone, 69% of the patients were locally controlled at 5 years. That by surgery alone, 69% of the patients were locally controlled at 5 years. And so vice versa, there were 31% local relapses after surgery alone. And that rate went down, or the local control went up, if you will, to 82% at 5 years if you added the brachytherapy. So the gain in local control was about a factor of 2, 31% versus 18. That's about a factor of 2. The study of Young, 1988, randomized 141 patients to surgery alone versus surgery plus what is now more the standard of postoperative to the entire area where the surgeon had been, and an 80 gray boost of the location where the original sarcoma had been. And in the Young study, we can acknowledge that the local control was 78% at 10 years versus 100% if you had your postoperative radiotherapy. But also for the low-grade tumors, there was a gain in local control for 68% versus 95%. Now, in slide number 17, I show that indeed there is an increase of local control from 69% by the addition of radiotherapy. And I show in the next slide, slide number 18, that the same holds true for the study randomized by Young. But in slide number 19, I highlight what happens if you just do that surgery. So that just doing surgery is about 60 to 70, sometimes 80% local control by surgery alone. You have to bear that in mind if you prescribe radiotherapy to every patient and discuss if radiotherapy is a good regimen for an individual patient. And again, as I highlighted, balancing the gain in local control, which obviously is there with a factor of 2, but there is some toxicity there, and you have to discuss that with your patient. This is what you can find on the Memorial Sloan Kettering Cancer Center. Fill in characteristics of a patient's age, the size of the tumor, the margins with which the surgeon was able to resect the tumor, the grade of the tumor, and the histological subtype. And you can get, where you can see on the right side of the slide, your results. If you press the calculation button, how much the gain of local control or the probability of local control was by just performing surgery on. That's surgery without radiotherapy. That's the answer you get on this prediction tool. It is based on almost 700 patients that were treated in New York and their region in the period 1982 to 2006, with a median follow-up of almost 5 years, which is relatively long for a disease like this, looking at whether you have your local recurrence or not. And that has been published in 2012. In slide number 22, I show you what is called a nomogram. It's sort of a calculation ruler where you can predict and calculate the percentages of local relapses at 3 and at 5 years. Let's have a closer look at this slide number 22 in slide number 20. Highlight, and I allude to the most unfavorable patient. The most unfavorable patient in this prediction model is a patient that's above 58 years of age, has a tumor larger than 5 centimeters, is closely or marginally positively resected, is a high-grade tumor, and is not an atypical lipomatous tumor. For those diseases, you will have a 40 to 50% chance on local relapses, or vice versa, 50 to 60% chance of local control. So this is what's happening. The set of high-grade sarcomas located in the extremity, being larger than 5 centimeters and deep-seated, about 50-60% of all the patients are locally controlled by surgery, and this chance goes up to about 90-92% if you add radiotherapy. 92% if you add radiotherapy. That's the gain we can show. But the optimist would say, if I would refuse my radiotherapy but find a good surgeon, he probably will give me a local control of 50 to 60%. And that answer is, I'm going to switch gears. Now we're going to look not at the discussion, are we going to irradiate, yes or no, but now we are looking to the fact that yes, we are going to irradiate, but how are we going to do that? And again, in slide number 25, I repeat the Canadian standard that this is the standard regimen we have to apply, and that's the regimen where we have most experience with. In slide number 26, I question whether there are alternatives. In slide number 27, I summarize in the 70s and 80s of the prior century by Dr. Eilber in UCLA, that's Los Angeles, where in 3 studies, each next to each other, he investigated whether he would give his preoperative radiotherapy to 10 times 3.5 gray, so per day more, but total dose less, and the time this regimen takes to apply is 10 fractions, so that's 2 weeks. And he got a very high chance of local control at 95% at 8 years. He appreciated at that time, between 1974 and 1981, that the wound complications after 10 times 3.5 gray radiotherapy were quite high, and he was dissatisfied with that. So in 1981 to 1984, he studied 137 patients, and he lowered the dose to 5 times 3.5 gray. What you can see is that the local control rate went down. So he lost some patients in their local control. They had to have second surgery because the radiation dose was probably too low. What he also appreciated, and he was quite pleased with that, is that the wound complication after that quite low dose of 17.5 gray was quite low. So in 1984 to 1987, he went in between with 112 patients, now delivering 8 times 3.5 gray. And what you can appreciate then is that, again, you get better local control, and he found at that time that the wound complication rate went down. And ever since, Los Angeles patients are being treated to a schedule of 8 times 3.5 gray in 1.5 weeks. One of the students of Eilber repeated somewhat the story with a little bit lower dose per day, but a little bit more fraction, so not 8 times 3.5, but 10 times 3. Study highly deviating from this regimen performed by the Polish group, published in 2014 on 272 patients, delivering 5 times 5 gray in 5 days in 1 week, and then surgery beyond the weekend. They found a local control rate of 81%. This is what happens if you are not prescribing a 2 gray per fraction regimen and deviate from 25 fractions. I'm going to highlight now in slide number 30, among the sarcoma subtypes that is known for its very high radiation sensitivity. In slide number 31, I show that when you look at these sarcomas during treatment, so from day 0 onwards to day 35, that's 5 weeks, so that's a 5-week regimen. In the blue lines, you will see several subtypes of sarcomas that are irradiated, and during this irradiation, they devitalize, they stop dividing, they stop growing, but they do not shrink. As opposed to that, looking at the orange lines, those are patients with myxoid liposarcomas, and they all shrink. Orange lines, those are patients with myxoid liposarcomas, and they all shrink. There is not a single myxoid liposarcoma patient that do not shrink, and there's not a single blue line that is mingled among the orange lines. So this is a very radiation-sensitive disease. And very striking in this observation when looking at these patients during treatment is that you see the shrinking of these masses already from day 14. So that's when you only have delivered 2 weeks of your 5-week radiotherapy schedule, these volumes are already shrinking. And that's when we can safely reduce the dose of preoperative radiotherapy in this disease. And we're currently investigating a study which we call the DOREMI. DOREMI stands for dose reduction of preoperative radiotherapy in myxoid liposarcomas. And we're lowering the dose to 18 times 2 gray instead of 30, 20 times 2 gray instead of 30, 25 times 2 gray in 35 days. The study has now accrued 71 patients worldwide, and we have currently in Amsterdam a PhD student who is going to analyze this study, and we expect to present the first data. Somewhere around summer next year. In slide number 35, I summarize all these studies we have seen up to now. And on the right side of the graph, you can see that the effect of surgery is local control for half of the patients. The local control is delivered by the additional radiotherapy, acknowledging and knowing that the addition of radiotherapy indeed causes some extra toxicity for the patients, and it takes longer time. From slide number 36, I go to discussing, are we on the right way treating sarcoma patients by just radiotherapy? Many cancer types are treated with a combination of radiotherapy and chemotherapy, and we know from these regimens that usually the toxicity is a little bit worse, but frequently these combination regimens have a higher chance of damaging the tumor and higher chance of local control and higher chance of even overall survival. So why not do this in the setting of sarcomas? To know what we are looking at and to understand what happens if you combine radiotherapy with chemotherapy, we have to know what happens by radiation alone. So in the top panel, you will see two studies by Dr. Kanter and Dr. Shah on 25 respectively 30 patients, delivering 25 times respectively 30 patients, delivering 25 times 2 gray. And what you see is in the almost last column, what is called near PCR. PCR stands for pathological complete remission. That is what a pathologist sees under the microscope when patients are treated to 50 gray. When patients are treated to 50 gray, then you wait 6 weeks, then you take the tumor out, and then you investigate under the microscope if the tumor is still vital. 8 to 10% of these patients after 50 gray have a tumor that is not vital anymore. So that's the information we have. Some of the studies till now have combined radiotherapy plus what I call conventional chemotherapy, like adriamycin and ifosfamide, in studies like 20 times 2 gray. And here again, by Dr. Ryan, you see the Los Angeles dose level again, and and also Dr. McDermott uses the 8 times 3.5 gray of the Los Angeles study by Albert. And in all these studies, except the one by McDermott, you will see that the combination of radiotherapy plus chemotherapy increases the chance that you get a pathological complete remission. Add adriamycin. If you only add ifosfamide, like in the study of McDermott, then that chemotherapy is probably not too high of an efficacy. More recently, we have all kinds of new targeted drugs, modern small molecules they are called, drugs to radiation. You will see on the last column that indeed the chance that you are damaging this tumor when the surgeons have to take them out is much higher. 20% with Avastin, 38% with sorafenib, 44% again with the sorafenib study, 40% again with the sorafenib study, 40% in my own study with pazopanib. All these regimens are more effective in making the tumor necrotic and making the tumor dead. And obviously, if the surgeon performs the operation after such a combination, the chance of leaving cells behind that are still viable, that are still alive, is much lower than when you combine that to radiation alone. There's a new study also performed by Dr. Bonvalot in a very world famous surgeon in Paris, and she is combining injecting some metal compounds in the tumor, and these metal compounds are then being irradiated, and highly sophisticated technique of which we have to learn more in the future, but also that study seemed to work. So what we have discussed till now, study seemed to work. So what we have discussed till now is that there are questions in the management of sarcomas we can address in the future, and we should be addressing together. And in slide number 42, I conclude that if you decide in your multidisciplinary team that a patient needs radiotherapy, and you decide that radiotherapy is delivered preoperatively, then the 50 gray in 5 weeks is the golden standard. But if you have a trial available for your patients, you to learn more, and these studies are going to question the fraction size, the dose per day, the total dose we're going to administer, and the combination with targeted agents like pazopanib and sorafenib. And we will learn in the future much more on these treatments than we know today. Having said that, I thank SPAEN so very much for this invitation, and I am happy to take any questions you may have.
Rick, thank you very, very much for your presentation. Showing your slides, so I apologize if we didn't show the right slide at the right time, so I'm very sorry for that. But I very much hope all our listeners have a lot of questions. Please unmute your phones, your speakers, your microphones, and ask away.
Hi, yes, I have a question. It's Andy Westwood in the UK.
Hi, Andy.
Hi there.
Hi.
Yeah, a couple of questions.
Amsterdam calling.
Hello. I'm a layman. I have no medical training, so I hope these aren't silly questions. But no medical training, so I hope these aren't silly questions. But just as you went through the presentation, there a couple of things struck me. One is there anything to be said about photon therapy as opposed to proton therapy as opposed to photon, and does it change any of the conclusions that you're making? Given that it's relatively new, and I guess not so much information out there about that. And then something else you mentioned, well, in terms of combination of radiotherapy with chemotherapy, and the idea that these sarcomas with two punches. And I remember from my own experience with this that some chemotherapy agents not only act against the tumor itself, but also act as radiosensitizers. And I just wondered whether you might explain that a little more, and maybe more, and maybe there's research going on into that, to find better radiosensitizers, if I've understood that correctly. If I could ask those couple of questions, I'll step back and enjoy my colleagues' questions.
Okay. Excellent.
And enjoy my colleagues' questions.
Okay. Excellent questions. I'm very pleased that you posed them. I'll start with the last one. Your question on the radiosensitization of chemotherapy. What you have to acknowledge is if a tumor cell is a cell, we also damage a little bit the DNA in normal cells that surround the tumor, but the very existence of my profession is that the normal cells are much more able to repair the damage that has occurred, and are much more able to repair the damage that has occurred, and are much more are much faster in that. So a normal cell, yes, there is a slight damage there, but a normal cell repairs and repairs quickly. When you look at a tumor cell, radio resistant, and there are some diseases that are radio resistant, but in cancer in general, the tumor cell that is being hit by radiation has DNA damage. They are less able to repair that damage, and they take a longer time. And that is exactly the reason why we do not deliver 50 gray in just one fraction one day. We repeat it each and every day again, so that the damage of the day before, let's say you start on Monday, you cause some damage. Overnight, the tumor cell is not ready repairing its damage. The normal cells are ready. The tumor cell, the damage of the day before, gets another hit. And the difference between normal cells and tumor cells, they grow out of each other along a regimen. And that is what radiation does. If you have another hit on the tumor cell, if you are able to damage them, not say by the front door, but also by the back door, and that is the different mechanisms. And each and every chemotherapy has its own mechanism of action, and hit the tumor from two sides. One side is chemotherapy, blocking the replication of DNA, let's say a compound like that. And at the same time, you give radiation. That makes even more damage to tumor cells. And that is exactly the way radiation sensitization works. And all kinds of investigations are being performed. In cancer, we use frequently cisplatin and 5-FU and mitomycin C. In sarcomas, you have seen the studies I summarized with adriamycin and ifosfamide. And these are all active drugs in the treatment of sarcoma. So that investigations have been done in the past. And perhaps should be continued. Your other question was about protons. Protons versus photons. Actually, when you deliver 2 gray by protons, it is the same dose and the same biological effect to the tumor, same in photons and in protons. But what is the major difference is that the delivery, the restriction of the radiation dose by protons is much more confined. So the tissues around a tumor get much lower dose when you deliver it by protons. Much lower dose when you deliver it by protons. That would obviously open the question, why isn't everybody treated with protons? Now, for one, because there are many tissues that tolerate radiation fairly well. For two, protons are very expensive. And number three, proton facilities are not available everywhere in reach of every patient. That is a major disadvantage, but it's a fact of life we have to live with. And I hope that would answer your questions.
And how that differs to standard radiotherapy, just very briefly?
Yeah, briefly, standard radiotherapy is usually with one beam for the half of the time coming from the front of the patient. Then the patient stays still lying on the table. The machine rotates 180 degrees and gives the second half of the treatment from the back. Then you have a large area that's being treated to a dose. You adequately treat the tumor, but you give a lot of dose to normal tissues. IMRT is sort of mimicking what protons can do. They confine the dose in that technique. They confine the dose in that technique coming from several directions with beams directed at the tumor. The dose you deliver to the tumor will remain the same, but the dose you deliver to normal tissue surrounding your tumor is much, much lower. And so the toxicity of IMRT is much lower.
Excellent. Thank you. Thanks for that.
Yeah, you're welcome.
So are there any more questions? Anyone? So actually, Rick, I do have a trial before. That is an international trial. Is it still recruiting?
Yep. Yeah, it is a study in which we continuously look because in fact it is a little bit difficult and it's a little bit weird if you are going to your doctor and the standard treatment is 25 fractions of radiotherapy once daily in 5 weeks. And then this doctor tells you, well, actually you have a very radiation sensitive disease, probably we can do less. Imagine yourself in the position he is suggesting to you, probably we can do less. So it is very difficult to convince patients to participate in that study. Currently, we started in 2010 with this very rare disease, and we have now 71 patients in that study. And the success of wound complications after that lower dose of radiotherapy is much lower. The wounds heal much easier and much faster, much less antibiotics, much less second operations, and the local control stays the same. Now, all these individual data have to be scientifically calculated, and my PhD student, Dr. Lansu, is currently calculating all the data that we have of these patients. And somewhere halfway next year, we hope to present publicly these data to be able for the future to state for myxoid liposarcomas we can deviate, and then you can have an easier talk with your doctor. Then he doesn't have to say, I have to prescribe you 25 times. Do you allow me to stop at 18? Then we can say, for this disease, 18 fractions has been proven to be enough. And I hope and live to see the day to prove that to my patient and to show for this disease, so radiation sensitive, 18 times is enough, and we maintain your anti-tumor efficacy, but we lower the rate of complications you have from this treatment.
Oh, wow, this is great, Rick. I didn't know you had some results already. Let me just point out, we do have the study registry on our website, and we do have the DORMI study in lay language explained there. So if you're interested in the study, take a look at there. So so you keep on your scientific work. That's great. So my last try, is there anyone else who would like to ask a question? Last chance. Anyone? Okay. Then, Rick, thank you very much for taking the time and for giving your presentation. It's been really great. We will definitely see you again in, Athens, I think, for the SPAEN conference.
Yeah.
We're looking